Hello, everyone. My name is Melanie Van Dyke, and I am a member of the Public Education Committee for ADAA, the Anxiety and Depression Association of America. Welcome to our webinar, Beyond Physical Appearance, Understanding Body Dysmorphic Disorder, with our presenter, Scott Granite. I am Dr. Melanie Van Dyke, and I am an associate professor of psychology at the University of Health Sciences and Pharmacy. I'm also a licensed psychologist at St. Louis Behavioral Medicine Institute, and this is our public education webinar. These webinars are presented by ADAA, the leading nonprofit organization in the field of anxiety and depression. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, just like this webinar, practice and research. We encourage you to take advantage of the many helpful resources on our website, adaa.org. Okay, let's get started. I am delighted to introduce our presenter. Scott Granite is a licensed clinical social worker who specializes in the treatment of BDD, OCD, and anxiety disorders at the OCD BDD Clinic of Northern California in Redwood City, California. He has presented on BDD at conferences worldwide and has taught continuing education courses at universities throughout the US. He's the author of The Complete OCD Workbook, a step-by-step guide to free yourself from intrusive thoughts, compulsive behaviors, and that is published by the Athena Press. He also is the author of Body Dysmorphic Disorder, Mine and Yours, a personal and clinical perspective, published by Toplight Books. As the title of the second book suggests, Scott also has lived experience with BDD, which has contributed to his dedicating much of his professional life to increasing public awareness of this often tormenting yet treatable disorder. I am pleased to welcome Scott Granite. So let me turn it over to Scott.
Okay, well, thank you very much, Melanie. It's wonderful to be with you today. And I really greatly appreciate the ADAA giving me this opportunity today. All right, so let me pull up my slides. All right, so once again, the title today, Beyond Physical Appearance, Understanding Body Dysmorphic Disorder. So why don't we go ahead and just get started with the presentation. So we'll start right off with what is BDD. So the essence of the diagnosis is that it is a perceived flaw in physical appearance. Now, the key word here is actually perceived, because whatever the supposed flaw is, typically is not noticeable to anybody else. I will say that in addition, part of the diagnosis is that if something in fact is present, let's say somebody has some acne scarring or some acne, other people would consider it to be minor. And so the essence of the diagnosis really is that people look normal. However we define normal, there are no actual flaws in physical appearance. And that is really the essence of the diagnosis. Another important part of the diagnosis is the presence of compulsive behaviors, such as mirror checking and comparing how someone's body part looks to other people's body parts. I'll get into that in a little more detail, but that is also another important part of the diagnosis because we do look for the presence of these kind of behaviors. Now, perhaps also very important is the significant impairment in functioning that is caused by this. Now, what's important in that is that we all have days where we don't like how we look. That's part of being human. And keep in mind that BDD is not simply a bad hair day. It does create significant problems in functioning. Most people, if they have a day where they feel like their hair doesn't look particularly good or they have a little bit of acne, don't think about not going to work or not going to school. But for somebody with BDD, that's exactly what may happen. So there is a significant impairment in functioning that comes as a result of this. Now, I always find it useful to talk a little bit about OCD and BDD together. And the reason for that is that, understandably, many people believe that BDD is just a form of OCD, which frankly it's not, but it's understandable that many people think that way. And for obvious reasons. And the most obvious one is the first one here, which is that both disorders contain obsessional thinking and compulsive behaviors. And I'll get into more about the compulsive behaviors in a little bit for BDD. But there are some important distinctions here between the two. One is that people with BDD are more likely to have relationship problems and be unmarried, and to have had an earlier onset of major depression and problems with social phobia or social anxiety, as well as psychotic disorders. I will say that I treat a lot of people with OCD. Many of them are not depressed. They have a significant problem with anxiety, and some are depressed for sure, but many aren't. In BDD, I see very few people with BDD who don't have a significant problem with depression. I would say that most do generally. Now, the next item here is really important for people to pay attention to. In fact, when I give my talks, I will say to people, if there's only one thing you remember from my talk, remember this next number, which is that approximately 25% of people with BDD make suicide attempts. That's just a remarkable number. And it speaks to that this is a very, very high risk population to work with. And so any clinician that treats BDD needs to be acutely aware of the presence of that. Now, I will say in more recent years, there's been some research that indicates that the suicide attempt rate with OCD may be quite similar. Based on my own practice, I will say that I don't see that as much. I see that there are many more people in my practice with BDD contemplate suicide than people I meet with OCD. I'm not trying to diminish the research that's out there. I'm just saying that in my own practice, I do see something different. Okay. Interestingly, there doesn't appear to be any differences in sex ratio and impairment in functioning between the two disorders. You would think that I think most people would think that with BDD, it might be a problem that affects more women than men, but that's not true. The research does indicate that there's a slight increase in this in women than men, but it is only slight. So basically, it affects men and women equally. Substance abuse tends to be more common in body dysmorphic disorder, mostly, I think, as a result of trying to self-medicate. And there are some other similarities between the two disorders is that the use of the same types of medications and cognitive behavioral therapy. However, what I will say, as we go forward with this presentation, one of the most significant differences, however, is in fact with treatment. Because if BDD is treated as if it's just OCD, people aren't going to get well enough. And so that's a very important issue that I will address a little bit later. All right, also important is that with the compulsive behaviors with BDD, they are less likely to relieve anxiety and distress like the compulsive behaviors in OCD do. People engage in compulsive behaviors because they know at some point that they're likely to contribute to their feeling better, at least in OCD. It may be very time consuming, it may be very disruptive to someone's life, but that's the whole point of the compulsive behaviors, is to find a way to achieve some relief. What often happens with BDD is the relief may come, 1 out of every 10 times, 50 times, or 100 times. But it's much more likely that it's going to contribute to some stress. It's just that people know that if they engage in compulsive behavior, at times they might feel better, and that's what drives it. Another complicating factor with BDD is that insight is generally poorer than it is with people with OCD. Now, what's meant by that is that a hallmark of OCD, not for everybody, but for many people, is that people understand that what they're thinking and what they're doing doesn't really make a whole lot of sense. They obviously feel compelled to do it. And it's one of the more maddening parts of living with OCD is that it doesn't make a whole lot of sense, but you can't stop it. With BDD, that's often not the case. People with BDD often believe that there is something wrong with their physical appearance, which is one of the challenges in treatment. We have to be able to find a way to get over that hurdle and improve people's insight. This last item here just means that for somebody with BDD, it's likely that there's also somebody with OCD in the family, because it is more common. If there's somebody within the family with OCD, then it's not uncommon that there may be somebody with BDD as well. Okay, so which body parts? We don't have enough time for me to tell you all the different body parts that may be involved with this, because really any body part that could be the focus of physical appearance could be the target of BDD, and I certainly see that in my practice. However, the most common body parts are hair, on the scalp primarily. And now it could be concern about thinning hair, but there's nothing to say that the concern couldn't be about having too much hair. Also, what we see a lot are people concerned about the skin, like in skin tone, and as well as the shape of the nose. So generally with BDD, we see mostly concerns around the head and the face. There is a subtype of BDD, which is called muscle dysmorphia. This affects mostly men, although it certainly can affect women. But in muscle dysmorphia, the concern is about someone's body build being slight. So it often results in exercising beyond what might be considered healthy or normal, taking supplements and perhaps steroids and perhaps to dangerous levels. And so it is a significant form of BDD. But again, the focus of attention with BDD can be on any body part. And, I've certainly seen people concerned about the shape of their lips, their teeth, the shape of their teeth, skin tone, as I mentioned, cheekbones, perhaps feeling that they're not symmetrical, lines on the face, such as wrinkles, breasts, penis, someone's height, and someone's weight. And so again, it really is limitless in terms of the body parts that can be paid attention to. I believe that, on average, people with BDD become concerned about 5 or 6 different body parts. And so it's more common that happens than people who are just concerned about one body part, and it stays that way over time. Although I certainly have met many people where that's the case. So in terms of compulsive behaviors, there are plenty that go along with this. One is probably the most common one is mirror checking. Or mirror avoidance. I probably see more of the checking behavior, as well as checking with other reflective surfaces. What I mean by that, it can be the computer screen, it can be the glass on the microwave oven, certainly store windows, car windows, truly anything that has a reflective surface. What I find interesting is that for most people with BDD, when I ask them how often they feel like they do the checking and they feel better, like I said a moment ago, it's rare actually. It can happen sometimes, but it speaks to the seduction of the mirror. Because again, people know that there is that chance that they're going to feel better, or somehow they're going to look one time and they'll notice something a little bit different. And that does happen sometimes, but again, more often it doesn't. And so a question that has to be asked is that if that's the case, why do it so much? But again, it speaks to the seduction of the mirror, knowing that it is possible that somebody may see something someday that looks different to them. Camouflaging is really exactly what it suggests, which is that people trying to find a way to cover the body part. It could be if somebody has concerns about hair, wearing a hat, concerns about skin. It could be wearing a lot of makeup. And I should say that could be for men as well as for women. Now, I put here, for example, wearing masks, and perhaps it's for obvious reasons, but what's really sad, there's a lot of things sad about this pandemic, of course, but I meet with many people with BDD. I wouldn't say they were happy about the pandemic, but many are not distressed about having to wear masks. In fact, it has allowed some people to be much more functional. Now, I don't think it's a good thing, obviously, and it's a sad commentary on what it's like to live with this disorder, that many people with BDD have found some relief through the pandemic. Excessive medical appointments and procedures, I'll address this in a little bit. Comparing the body part, this can be in person, it can be on TV shows, it could be, of course, searching the internet, but basically comparing how their body part looks to the body part of somebody else. And the comparisons are usually negative, of course. People comparing themselves and feeling like, they don't look good compared to the other person. Now, this also speaks to one of the problems with social media and BDD. With social media, people don't generally post pictures of themselves looking bad in places they can't stand being. And so people have to be have to be very careful about that. People are often posting pictures that have been edited in some way, have been filtered. And so you just have to be careful when you're doing that, because you're not necessarily seeing how somebody really looks. And we all know that.
And I was going to say, Scott, that it really reminds me of what you were saying about kind of trying to get reassurance from the mirror, that the comparisons also aren't really giving the relief that the person was really looking for.
That's right. And it very, very rarely brings any relief. Excessive grooming rituals, we see that a lot with BDD. Sometimes touching the body part can be a compulsive behavior. In other words, if somebody has concerns, let's say about the size of their waist, they may touch their stomach just to measure it somehow. I've known people who have had concerns about hair and have measured how much their hair is growing. That's hard to do on a daily basis. I don't really think you're going to notice by doing that, but it doesn't stop people from doing those kind of behaviors. I've known people who have had concerns about the shape of their head or the size of their head, whether it's too small or too big, and taking a tape measure and measuring the size of their head. What's so interesting to me in that is that some days people will measure their head and feel better, and some days not. And you would think that the size of the head doesn't change at all. So it's really one of the remarkable aspects of this disorder in terms of how someone's view can change day to day. In terms of skin picking, one of the important things for me to mention about skin picking is that we have to look at that from a differential diagnosis perspective. And what I mean by that is that if somebody is picking their skin and the emphasis is on trying to improve their appearance, then it's related to body dysmorphic disorder because it's appearance related. However, if it's skin picking to maybe smooth out a part of their body, or maybe it's an automatic behavior that they're doing oftentimes without giving it much thought, then it could be more what's called excoriation, which is the skin picking disorder. Skin picking, if it's more in terms of self-mutilation, it may be more of a reflection of borderline personality. And so with skin picking, whenever I meet with people who pick at their skin, and in being an OCD specialist, I do see a lot of people with these types of problems. One of the questions I always ask is, does it have anything to do with how they look? And I think all clinicians need to be asking that question, because that can often open the door to a discussion about BDD. And lastly, reassurance seeking. I find that this is maybe less common in BDD than in OCD. With OCD, I think reassurance seeking is the primary compulsive behavior. There's a lot of that with BDD as well, but because there's so much shame with BDD, it may not necessarily happen quite as much, but I do know many, many people who also will ask, especially people close to them, what they think about their appearance. However, I have known some people who post pictures of themselves on social media and will ask others for reassurance. And unfortunately, social media being as anonymous as it is, that doesn't always work out well. There are some very cruel people on social media, and the comments that people often get when they do that can be less than kind. But reassurance seeking is something important to consider with BDD as well. All right. I do like to talk a little bit about the prevalence of BDD, because some of these factors are going to be very surprising. The estimates are approximately 3 to 5 million people in this country have BDD. Now, in the book I wrote that Melanie alluded to, the number I gave was 5 to 10 million, because I have seen research that indicates that. Now, if that's the case, BDD is more common than OCD, much more common, frankly. And if that's true, where is everybody? How come more therapists aren't treating people with BDD? Now, I'll address that in a moment, but it's a striking number, and it's really striking to consider that this may be a much more common disorder than people realize. I did mention a little bit earlier about it affecting men and women equally. Age of onset with BDD tends to be in the earlier teen years, and that makes sense because of what's going on both socially and hormonally. And so often that's when BDD will first surface. In inpatient settings and hospital settings, it's indicated that about 13% of people with may have BDD. And when you think about it, that's a remarkable number. That means more than 1 in 10 people in a psychiatric hospital may have BDD. Remarkable. Now, in dermatology settings, in my experience, dermatologists and plastic surgeons come into contact with people with BDD far more often than mental health conditions do. And so, as you see here, up to about 16% of people in dermatologic settings may have BDD, which is an amazing number. It's not surprising to me. The issue that concerns me is how dermatologists and plastic surgeons react to somebody with BDD. I've seen in more recent years that dermatologists and plastic surgeons have become much more sensitive to this. And if they determine that somebody has BDD, oftentimes they will recommend that somebody seek therapy first, and I've certainly have experienced that with many of my clients. But as you all know, if you see enough doctors, you're going to find somebody who's going to do a procedure even though you don't really need it. And so that's one of the dangers of this. And I will talk a little bit more in a moment about the pitfalls of plastic surgery with BDD. A lot of people with BDD have problems with social phobia or social anxiety. This number is 11 to 13%. And I would, in my practice anyway, I think the number has been far higher than that. I can't give you an exact number, but I would say it's much higher than that. And also many people who are receiving treatment for anxiety and disorders have BDD. So these are really some remarkable numbers. Again, it speaks to the notion that BDD is probably much more common than people have realized. Where is everybody? We know that there are a lot of people with BDD out there. And yet there are so many clinicians who never have met somebody with BDD. And the general public, in fact, doesn't really know much about BDD. Although I will say that in recent years, it's very encouraging that more people do know about BDD. But there is a tremendous amount of shame associated with BDD. And so people are often just not going to seek help. There's too much shame associated with going to a doctor or a therapist and talking about how they look. Now, they certainly may go see a therapist or a doctor about feeling so anxious and depressed, and still, though, may not reveal symptoms of BDD. As I've said, seeking medical appointments and procedures. And, frankly, that only makes sense. If you think of somebody who has concerns about their nose being misshapen, frankly, their first thought is probably not going to be, gee, maybe I should see a psychotherapist. I understand that. The first thought is probably going to be, I'm going to get this problem fixed. Again, the issue becomes what happens after they go see the doctor, but it's understandable that people first go to seek some kind of medical remedy. And frankly, when people do go for therapy, they're often misdiagnosed. I remember early in my years of treating BDD, this was, 25, 30 years ago now, but I remember reading an article on BDD for the first time. And, as Melanie alluded to earlier, I've had BDD myself for a very long time. And I was treating people with OCD and didn't even know I had BDD. I knew I had an issue with my body. I just didn't know there was a term for it. And when I finally read this article and discovered, wow, there was a term for it, I began meeting people with BDD. But before then, I remember one man coming to see me, and he complained about his face was red. He was obviously depressed. I just couldn't figure it out. I didn't know. I just thought, I gave him a diagnosis of depression. And that was it. I often think of this man and think if he's still suffering, I'd like him to reach out to me because I think I know what he has, and now I think that I could help him. And I think that many, many therapists find themselves in the same position where people come to therapy, talk about a body part, and therapists don't really know what it is still. So hopefully that's changing, but I know it's still the case quite often.
Yeah, and Scott, one of the things that I found is that sometimes my patients with BDD will also doubt that they have BDD, with a real common statement: what if my appearance flaw is real or more than minor? And so what would you say to someone who thinks maybe they got misdiagnosed because of the severity of their flaw? Can they still get better with treatment?
Absolutely. It's an interesting question, and you're right. It comes up all the time, and people have asked me that plenty of times. The question that we have to take a look at with that, is there a real flaw? Is there a real deformity or flaw? And if there is, then it's not BDD, frankly. If somebody has, I've met with men, I think it's called gynecomastia, which is enlarged breasts. And so I've met with some men with that. I forget the medical term for this one, but it's a sunken chest. I think that's what it's referred to. And so that's a real medical problem. But the issue with that oftentimes is that the way people are reacting to it is they're reacting to it with much more distress than would be considered normal. And so I do think it's worthwhile treating people like that as if it's BDD. Now, I will say that in the DSM, the word ugly isn't used at all. And so when people talk about being ugly, we have to really help them to define what that actually means. By whose definition are what are they? How are they defining ugly? And that's really an important part of the therapy. What I often will say to people is that, wouldn't you agree that regardless of how anybody looks, they deserve to be happy? And for most people, the answer, of course, is yes. And so we have to then be able to take a look at, well, what's going on? Why is this creating the torment that it does? Now, at the same time, I have had people say to me, and somebody said this to me yesterday, actually, that I'm so ugly, I don't deserve to live. I don't deserve to be happy. Well, the answer to that is very complicated, and that there's a lot of therapy that goes into that. But at the same time, this very same person told me that she understood that the way she feels about her appearance is different than other people do. And a lot of people with BDD, even those with poor insight, will often agree with that. And so that too has to be part of the therapy. I will mention one other thing about this, that in the DSM, under OCD, there's a subcategory that is the terminology is body dysmorphic like disorder with actual flaws. Remarkably, many therapists don't even know that exists. But this didn't exist as a diagnosis. It's not really a diagnosis, but rather a subcategory. And it didn't exist in prior editions of the DSM. But now it's important because it does help to categorize people who actually do have flaws in their physical appearance. Melanie, I feel like I've given you a long-winded answer on this, so I hope I've answered it.
Oh, I appreciate it, because it's such a common question that I get. And so thank you.
Sure, of course. I don't spend a lot of time here on causes because, frankly, nobody knows what causes BDD. But we do have some ideas. We know that with OCD, OCD is very much driven by neurobiological issues. And we believe that much of the same can be said with BDD. And I don't doubt that that's a significant part of it. I do want to mention a bit about societal factors and social media. Many people will say to me, well, of course they have BDD. We live in a society that's obsessed with physical appearance. Well, I don't believe that's a causal factor, though. All of us, whether you have BDD or not, are exposed to the same social media, to the same images on the internet to people in movies and TV shows and magazines. And yet a relatively small percentage of people wind up with BDD. And so I certainly agree that societal factors can exacerbate symptoms of BDD, for sure. But whether it causes BDD, I just don't think so. I do meet with a lot of people whose family put a tremendous emphasis on appearance, and that can be a causal factor. And there are other factors to pay attention to, such as being teased at a young age and developmental trauma, which I'll get into in a moment. Now, in my speeches and in my book, I do often mention that everyone has a story. Now, I will admit, I have not met everybody with BDD. However, everybody that I meet with tends to have a story. And what I mean by that, and this is where I believe BDD separates itself from OCD. Again, with OCD, it's really, the treatment is all about trying to get rid of as much of the obsessive thinking and compulsive behavior as possible. We're not really trying to delve into, what brought this on, what happened in your background, because we know with OCD that generally that's a waste of time. People have done a lot of that therapy over the years and haven't gotten better. And so the emphasis is very much on a specific form of CBT that I'll talk about. With BDD, however, I think just doing that is a mistake, because most people do have a story, and we do have to understand what their story is. Now, the people that I have come across, many people have had abuse in their background, both physical and sexual. There has been neglect, bullying, such as bullying at school or bullied by siblings and other people. There is some interesting research about this, which indicates that about 80% of people with BDD have some kind of childhood maltreatment in their background. And so it baffles me when therapists don't address that in treatment. Again, I think that if that's not addressed in treatment, people aren't really going to get well enough. And so for me, that again is one of the issues that separates OCD and BDD. Other factors to keep in mind is that in terms of my own experience, I've seen mostly men who are were teased at a younger age because of being smaller. Some women I've met were teased at a younger age because of being taller than other kids. I mentioned earlier about a family focus on appearance, not just physical appearance, but on excelling in a lot of aspects of life. I've met with actually a couple of people whose their fathers have been bodybuilders, and that seems to have contributed to their own issues regarding their body. And many, many people with BDD are shy and socially withdrawn. So again, all of this, if it's in somebody's background, needs to be part of the therapy. We need to understand not just the causal part of this, of what may have contributed to the BDD, but also how this impacts somebody's current function. So both elements of that I think are important. And to be honest about it, there's very little written about it. And I do think that our understanding of BDD is probably a generation behind where we are with OCD. So, I am hoping that as years go by, there will be much more written about this and studied about this. So in terms of treatment, the research indicates that there is about 70% improvement when people take the serotonin drugs, and also significant improvement with cognitive behavioral therapy. Now, what's sad about this is that 70% may sound good, but what if you're in that 30%? And so our goal needs to be also to help those 30%. The best treatment is considered a combination of CBT and medication. Now, I do want to spend a moment on the medications that we use for BDD. There's a lot more that can be tried than these medications. But for the purpose of today's discussion, the serotonin drugs, the drugs that work on the neurotransmitter serotonin, are the ones that are tried first. Now, this is true with OCD as well. So the one thing I'll mention is the first drug, clomipramine, or also referred to as anafranil, is in a slightly different class of drug called an SRI versus the SSRIs, meaning selective serotonin reuptake inhibitor versus the selective serotonin reuptake inhibitors. Clomipramine, however, is an older drug. It's classified as a tricyclic antidepressant. And so it does come with more side effects oftentimes. And so it's not generally the first drug that's used. It's often used as an adjunct to these other drugs. However, it can be effective, and I've known many people who have taken it. I'll just mention a couple of things about the dosing, is that what you see here are the drug manufacturer's range for depression. All these drugs were first approved for the treatment of depression. There are no drugs that were just approved for BDD. If you're somebody with BDD as well as OCD, the dosing typically has to be on the higher end. I mean, that's very well known. And frankly, if a psychiatrist is comfortable treating these disorders, the dosing often goes beyond what you see here as far as the high end. Now, another important factor for patients to consider is that it may take a while for these drugs to work. We know that it could take 8 weeks, 12 weeks, or even longer sometimes. And you know, as a clinician myself who doesn't prescribe medication, I often have to encourage people to stick with it, because oftentimes, I've seen this many, many times, people will take these drugs and after a month or so feel like they're not working and stop them. And they just haven't given it enough of a try. And I know it's frustrating. I know we want these drugs to work more quickly, but we know that in order for them to work, people have to be patient and stay on them for longer. What's interesting, I will say that people often ask about antipsychotic medications, especially for a delusional form of BDD, which I should have mentioned earlier, is that many people with BDD, in fact, can be delusional, meaning that they see something in their appearance that just isn't there. But it is known that these drugs, the SRIs, are as effective with treating that form of BDD as the antipsychotic medications can be. So there's no need really to add the antipsychotics for that purpose. What doesn't appear, I just mentioned, well, it doesn't appear to work are the antipsychotics when used without a serotonin drug. I already mentioned that, well, the older tricyclic antidepressants are not known to work except for naftaline. ECT, electroconvulsive therapy, can be helpful to depression, but it's not known to be useful for BDD. And neurosurgery, there are very limited case examples of this, and I don't think that there are any, I don't think anything's been approved for BDD. So it's very, very rarely done when it comes to now, the issue of plastic surgery. One of the more tragic things I come across in my work is when I meet with somebody who has already had plastic surgery and is even more upset as a result of it. You can't turn back. Once you have the surgery, you can't go back to the doctor and say, you know, I changed my mind. I want my old nose back. It just doesn't work that way. And so what people have to be careful about is that the most likely outcome for people with BDD who have plastic surgery is that they don't like it, and then they pursue other procedures, or another body part becomes the focus of concern. If somebody does like the change, another body part will become the focus. Now, all of this only makes sense because we have to consider that BDD is a psychiatric problem. So how can a psychiatric problem be fixed with plastic surgery? It can't be. It just doesn't make any sense that it would. I think what I'm saying makes a whole lot of sense. However, I know that if, you know, there's so much to spare with BDD that people do it anyway. They just, you know, they often feel that life hinges on their being able to change how they look. And so I understand that. I understand the desperation that's caused by this. But I do also think it's my job to give people the facts about this. I think the percent is something like, I think it's somewhere around 5% of people who have BDD have surgery like the results, which means that there's a 95% chance they're not going to like it. Now, if you're somebody who goes gambling and you go to a casino where there's a 95% chance you're going to lose, would you go there? Probably not. So why treat your body like this? I realize the answer to that is much more complicated. Psychodynamic in-depth psychotherapy, I put a bunch of question marks in there because it is sort of a pet peeve of mine, because I know a lot of people have said in the past anyway that it doesn't play a role in treating BDD, but I greatly disagree with that for reasons I stated earlier. I think CBT is important, but I think there needs to be an element of more in-depth therapy as well. We know that as good as dieting can be for some people, and exercise and some other natural remedies and hypnosis, we also know that it doesn't do a dent in terms of BDD. Doesn't make a dent, I should say. Exercise, certainly excessive exercise. Exercise is good for a lot of reasons, but many people with BDD will just do it in excess. So as far as going further in the treatment, cognitive therapy can be very important. Cognitive therapy is all about trying to challenge someone's distorted beliefs. Now with BDD, it's all about distorted beliefs. And so helping somebody to be able to get to a point where they're thinking differently about their appearance and don't have to experience so much despair, that's one of the bigger challenges in treating BDD. And behavior therapy really is meant to accomplish the same thing by challenging somebody's maladaptive coping strategies. The hope is that somebody's beliefs will begin to change. Well, now the primary treatment, as far as behaviorally, just like with OCD, is exposure and response prevention therapy. I'll get to that in a moment. In cognitive therapy, we want to try and weaken the beliefs, and we also want to try and weaken that appearance is as important as somebody believes that it is. Now, again, I recognize that we live in a world that seems to be obsessed with physical appearance. However, most people, again, if they have a day where they feel like they don't look good, don't think about killing themselves. And so it speaks to the significance of how somebody looks, when they have BDD. And so that's a big part of what has to be worked on with this, is that we need to find a way to weaken the association between the meaning that life has and how somebody looks, because it's just not that way for most people. And so in terms of some of the goals of therapy, that's what we're looking at. We want to weaken that kind of association. And we need to be able to confront that someone's happiness and success and life satisfaction is linked so closely to appearance. I have many, many people say to me that however they look on any given day will determine how they feel about themselves. And again, that's just not the way it works for most people. Again, if you wake up one day, if you don't have BDD, your hair doesn't look great, it's like, oh, well, I got to go to work. That's about the end of it. And so that's a very important part in the cognitive side of this, is that we are trying to weaken that link. At the same time, many, many people with BDD are dysfunctional in a lot of areas of their life. And so especially with relationships, whether they're romantic relationships, family relationships, friendships, they also can have difficulties with work and school. And so we want the really important things in life to be important. We want those issues to become more important than the body is. And again, so that's one of the goals, is that we want people to focus on the important things in life and weaken the meaning of the body part. Now, on the bottom here where I put important goal, I know how overly simplistic this sounds, in that ultimately feeling good has to be more important than looking good. Now I phrase it that way because CBT and therapy in general is just plain hard work. And so rather than the emphasis on trying to look better as a way of getting to feel better, and keep in mind that that's what this is all about, is that people are trying to find a way to feel better through their appearance. So rather than doing that is really to work on other aspects of life and do the hard work of therapy to get there. Core beliefs. This isn't done as much with OCD in terms of core beliefs, in terms of how somebody feels about themselves. Core beliefs, we often think of core beliefs with OCD in terms of what's the core fear, but that's different in terms of how I'm referring to core belief in this sense. And so we want to be able to have some people with BDD will feel like they have to look perfect. Now in my experience, that's not often the case. For the most part, people with BDD just want to fit in. They don't want to stand out. But some people do have this feeling that they have to look perfect. And so we need to address that in therapy. Because how many people wind up looking perfect? Not many. We want to focus on the core belief of life has meaning if I look good. Well, how many people feel that way? Again, if you don't have BDD, that's probably not the case. I'm unlovable and worthless if I don't look better. One of the most awful things about both living with BDD and treating people with BDD is hearing people refer to themselves as disgusting, as ugly, as a monster, all sorts of terrible words. And so we need to address that. We need to understand where are these core beliefs coming from and work towards changing those core beliefs. And lastly, if I don't look good, people will treat me poorly. In other words, one of my frustrations in treating people with BDD is that I can't tell you how many people have said to me, look, I've gone online, I've seen the research. It says that people who are better looking get the better jobs and they'll date more attractive people. We know that research is out there. But for those people who aren't in the category of more attractive people, what do? Do they just not date? Do they just not get a job? Well, of course not. There are many people. I mean, it's called average for a reason. Most of us look average, and most people find a way to be happy and find a way to have, successful lives. And so this too is a core belief that needs to be addressed. Anybody who's done exposure therapy knows that it is extraordinarily hard work. It doesn't need to be painful, and it shouldn't be painful. I think it needs to be done in a very step-by-step way. I often look at exposure therapy as a very collaborative approach between me and my patient. It's never me just telling my patient what to do. We're working on it together. It's important to consider that in doing exposure therapy, which is referred to exposure and response prevention, both elements have to take place. And I'll mention, in doing exposure therapy, it's probably easiest to give an OCD example, which is that if somebody has a fear of fire and they have trouble using the oven, it's not enough to say to somebody, use the oven. That's the exposure part. We have to add the response prevention, which is not doing the compulsions, which is not checking the oven for 5 minutes or for 20 times or whatever. So both the exposure and the response prevention have to take place. With both OCD and BDD, I think a very important part of exposure therapy is the willingness of the patient to take risks. Now, these aren't risks to anybody else except those with OCD and BDD, but they are going to feel like risks. If you're not somebody who has these disorders, going out to dinner, for example, without makeup may feel uncomfortable, but it's not going to feel life-shattering. But with BDD, it can feel very, very difficult. And so it means being able to take some risks. I think one of the factors that's different in exposure therapy with BDD oftentimes is that we need to process what's happening. And oftentimes when somebody's doing exposures, perhaps somebody's in my office and I've asked them maybe to come in and wear a shirt that they feel is tighter, that may be exposing a part of their body that they are uncomfortable with. I want to be able to talk to them about it. What are they feeling? What emotions are coming up? What thoughts are popping up? Can we work towards thinking differently? Can we work towards the anxiety and the discomfort lessening? And so to be able to process it and talk about it as it's happening is really very valuable. And so in that sense, it really is more than just anxiety and symptom reduction. We're trying to help people to understand the feelings that are generated and the thoughts that come up and be able then to just sort of feel differently about what's happening. This is the cycle in terms of exposure therapy is very similar with BDD as with OCD. I'll just give a BDD example. Let's say we have somebody go out to eat. That could be the trigger. That'll trigger the obsessive thought that the lighting is bad, perhaps, that people can see, let's say, somebody's nose more clearly. The compulsive behavior may be an impulse to change tables, to sit somewhere where the lighting is different. And we know with the compulsive behavior, the reason to do that is that the person may feel better because they're in a situation that doesn't expose how they look as much. Now, sort of the exposure therapy would be having the person do that, go to a restaurant. We know it's going to trigger the obsessive thought about the lighting and not looking good. Blocking the compulsion or the response prevention is sitting there. Don't change, don't change the table. Experience how they're feeling and what they're thinking. And hopefully do that long enough until the relief is there is some relief that surfaces. And we know when people hang in there with these exposure exercises, that the anxiety will begin to diminish because it has to. Anxiety will wear itself out. I say this all as if it's so easy. And we know, of course, that it's not. It's very hard work. But this is just an example of how we might use exposure therapy for BDD. I don't really have the time to go into all this in detail, but just like with OCD, we would put these exposure exercises in a hierarchical fashion, starting with items that are easier perhaps to do, and moving up to those items that are more difficult to do. This was somebody who had concerns about their hair thinning. Now, to be completely honest about this was one of my personal hierarchies to work on. So it wasn't a patient of mine, but my own. And so my concern has always been hair. And so the first thing wasn't easy, but was for me to resist the mirror checking when I woke up in the morning for 15 minutes. It got to be much more difficult. Looking at the comb and the brush. I mean, what's in combs and brushes? Well, hair, of course. I didn't like seeing that. And so my job was to see it, experience the anxiety, and it did create a lot of anxiety, but over time, that anxiety did diminish. And it got much more difficult. It was the last one, which was taking hair from the brush and placing it in the sink and leaving it there. So I had to look at it during the course of the day. Very uncomfortable for a while, but over time, I just essentially got used to it, and it didn't bother me as much. And so this next hierarchy is about makeup, or someone's concerned about skin. And again, I won't go into a tremendous detail, but you can see the most difficult one for this person was going to dinner with friends without makeup on. So again, I think one of the things I'd like people to know in terms of doing therapy for this is that your therapist is not somebody who's going to force you to do any of this. And I think that that's one of the issues that people are afraid of when they come for therapy, is that they feel like they're going to be forced to do something they're not ready to do. And if that's the case, you probably need a new therapist, because I do think that's not the right way to go about it. It's our job as therapists to push our patients. Maybe encourage is the better word. But we can't force anybody to do anything. And if somebody says they're not ready to work on something, then there's plenty of other stuff to be working on until they are maybe ready. So I know we're getting to the point where we're likely to have to finish. These are just some other examples of behavior therapy. In the beginning, I do think one of my colleagues talks about the 6 p.m. rule and the arm's length policy. Whereas, if you're at home, and let's say it's after 6 o'clock, doesn't have to be 6 o'clock, but what's the point of looking in the mirror, really? If you've worn makeup, all right, I guess you have to look in the mirror to take it off. But beyond that, there's no point in going to the mirror. And so really try not to go there, because if you go to the mirror at that point, you're probably doing checking. And if you're doing checking, you're leaving yourself vulnerable to make things worse. The arm's length policy, same kind of thing. Is there any need to get any closer to the mirror than an arm's length? Probably not. If you are, you may see something like we all might that we don't like. And so that's an important issue to really keep in mind with this. Other issues here are, let's say if the concern is about acne, perhaps going out with less makeup on or none at all. If concerns about weight, perhaps wearing tighter clothes. Teeth, maybe I meet with some people who may, when they're talking to some people, cover their hands when they're talking so that it doesn't expose their teeth. So try going out and not doing that. We want people to, I know that this is a very unfortunate part of doing exposure therapy, is we want people to experience these uncomfortable feelings. We want people to know that they can experience these feelings and get through them. When you're busy doing these compulsive behaviors, you don't get to that point. You're always relying on the compulsive behavior to feel better. We want to help people get to the point of recognizing that that's just not necessary. All right, well, I've reached the end here. I do think that education is a very important part of BDD. There's a lot of misinformation out there about BDD, but there's a lot of good information as well. And so part of my role is to educate people about what BDD is and what it isn't. Treatment can be very, very effective with BDD. The problem is that there aren't enough therapists still who treat this problem and treat it effectively. But that's changing. And fortunately, now that we're in an era where many people are doing remote therapy, which can be remarkably effective, much to my surprise and pleasure. Early in the pandemic, I thought my career was over, but I have been very, very pleased with how well remote therapy has gone. And so you're no longer limited to somebody to a therapist just in your immediate area. There may be concerns regarding state licensing in other states, but you can go beyond just your local area.
Yeah, and Scott, if I can ask, what does recovery look like in BDD? What can people hope for?
Well, what people can hope for in recovery is that this just isn't as important. We know, just like with OCD and other similar problems, we're not talking about this problem going away entirely. But the hope is that somebody feels a greater sense of control over this than it has over them. And that people can get on with their lives, that the important things in life can be important, like relationships and school and work. And so what we want is for somebody to be much more functional. And not just to be functional, but of course, to reach a point where they're really happy and satisfied with their life. And so what's important in that question to me is that treatment is not just about feeling better about how you look and not being as distressed over it, but more importantly, it's about getting on with your life and having a life that you feel is worth living, and learning that that appearance just isn't as important as people with BDD make it out to believe. So with that, there is very good reason to feel hopeful. And frankly, when I first started showing symptoms, BDD was not even a recognized diagnosis. And I think it was more than 10 years before it was included in the DSM-3R at that point. And so I first began showing symptoms when I was 20, or 19, I should say, and didn't receive a diagnosis until I was 40. So I went a lot of years with thinking that I just had a part of my body I didn't like, and without recognizing that it was a psychiatric illness. And so the hope here is that people don't have to do that anymore, that much more is known about this problem and many more people are aware of it. A couple of other things I just want to mention, my shameless plug here. This book came out earlier this year. As you can see from the title, it's partly about my own story about living with BDD, partly about the stories of some of my clients, but it's also it's not so much of a workbook, although there are workbook elements, but it's also meant as a guide to treatment too. And so there are parts of this book in which I would have been, what's the right way to put it, painfully honest about my own experience. And so I know that some people who have known me over the years may be surprised about some of it. Very personal telling of my own experience. And one last thing I'll mention is that when I first saw the cover of this book, I immediately sent an email to my editor and said, can't we put something more positive? Why does it have to be this zombie-like creature? And I thought about it, and of course this was all up to the editor. I had very little input in the cover. And then as I thought about it, this is the right cover. It does portray the the torment, and that's the right word, the torment that people with BDD go through, and the shame as well. And so I do think this is the right cover. So lastly, I don't know how many times I've said lastly, but this is the last one. This is my contact information. I'm always happy to respond to emails and questions, anything that comes up. If you'd like to reach out, please feel free to do so. Melody, I want to thank you and the ADAA for giving me this opportunity, but any other questions you'd like to ask?
No, I think I would really like to thank you for your excellent presentation today, and be able to share with our viewers that we would welcome them to also they can contact the ADA if they have additional questions, and they will get those to you as well. So they have
Perfect.
2 different ways to be able to do that. We also invite folks to be able to visit ADAA.org so that they can see all of the resources that we have. We have a list of therapists. So if people are looking for help, we do have the Find a Therapist feature. We also have a free online support group for folks. And so we want to make sure that people know about those resources. In addition, if anyone is interested in supporting ADAA, they can make a charitable donation through our website, adaa.org. And we want to thank everyone for watching our webinar. So thank you very much. We encourage you to like and to share it so that other folks can find out more about BDD and its treatment.